Okay, so the topic we're going to discuss today is bisphosphonates, and this is a topic that does come in the exam quite a bit. It can come in OSCEs, it can come as part of the DTP, so it's important to cover it. Now, um, bisphosphonates are medication that's given to patients. Now, let's first discuss what normal bone is like. In normal bone, there's two processes that go on at the same time. There's resorption and then there's also deposition. Now these two processes go on at the same time and cause bone turnover. This is something that happens in normal bone. Resorption is something that's taken care of by osteoclasts, and deposition is something that's taken care of by the cells in the bone called osteoblasts. Now, what happens in the bisphosphonates, or patients who take bisphosphonates, the medication basically inhibits osteoclasts, and these are cells that cause bone to wear away or bone resorption. Now, if bone isn't being worn away and there's decreased bone resorption, that means there's decreased bone turnover, which means that the bone becomes more dense. Now, when something becomes more dense, it becomes difficult for the blood to reach all parts of it because it's so dense, and it decreases the blood supply to the bone. Now, that's fine, but in these patients, there's a risk that if there's any injury to the bone, it can lead to bone necrosis or bone death. And if patients are on bisphosphonates, and this is something that hasn't healed in 8 weeks, and they haven't had any radiotherapy in the past, then this is something that we can diagnose as bisphosphonate related osteonecrosis of the jaw. And it's sometimes titled as BRONJ or BONJ. Now, coming to what we can do try and find prevent this disease is, first of all, we have to take a patient's thorough medical history, which includes the drugs they're taking and any diseases that they have. The reason why we also ask about diseases is because the patient may forget to tell us that they're taking a bisphosphonate. However, if they tell us that they are taking alendronate or Fosamax or risedronate or pamidronate, that would be the drug. And if they say that they are suffering from osteoporosis or Paget's disease or bone cancer, then we can then ask them what medications they're taking for that, or if they're taking any bisphosphonates, because patients with osteoporosis especially may be taking bisphosphonates. Other than that, when treating these patients, we have to give good preventative advice. This includes making sure that they carry out good oral hygiene measures, brushing twice a day. Their diet should be low in sugar to prevent anything like tooth decay, because if something like tooth decay is left untreated, patients may need the tooth extracted if it's beyond saving, and then extraction can lead to it may make the patient at risk of developing bisphosphonate related osteonecrosis of the jaw. Ask the patient to decrease alcohol consumption, stop smoking, and we need to regularly see this patient in the dental clinic, just so we can catch something before it gets worse. Preventive treatment should be given to the patient. For example, if there's the beginning of case, we should treat it as early as possible. Same goes for periodontal infections. Any ill-fitting dentures should be also treated as soon as possible and fixed, because if the denture is ill-fitting, what it does is it then causes trauma to the underlying mucosa, which can then cause trauma to the bone underneath and may lead to necrosis of the bone. We have to try and avoid all treatment that impacts the bone. Of course, if there's any treatment that can't be avoided, we should proceed with that option. But if we can avoid any treatment that impacts the bone, this includes extractions, implants, any kind of procedure that involves raising a flap. Now, coming to the risk of developing bisphosphonate related osteonecrosis of the jaw. This can be classified into two categories. There can be low risk or high risk. Now, if a patient is in the previous guidelines, the patient was classified as low risk if they were taking any form of oral bisphosphonates, and high risk if they were taking IV form of bisphosphonates. Or it was even classified as how long the patient has been taking the bisphosphonates. Now the latest guideline says that it depends on what they're taking the bisphosphonate for, not how they're taking it or how long they've been taking it. So a low risk patient for developing bisphosphonate related osteonecrosis of the jaw is a patient who patient at the start, before they start the treatment, bisphosphonate treatment, or if they're taking bisphosphonates for osteoporosis. These are patients basically who are low risk. And in these patients, what we do is, if we can't avoid surgery, we have to make sure it's done as atraumatically as possible. We have to avoid raising flaps and make sure that there's good hemostasis. Now, in these patients, we're going to review them in 4 weeks. If we see any signs of bisphosphonate related osteonecrosis of the jaw, we're going to refer them to OMFS. And these signs can be like numbness, pain, any kind of healing that doesn't, non-healing, basically refer to OMFS. Now coming to high-risk patients, if a patient has had previously bisphosphonate-related osteonecrosis of the jaw, then they're high risk. It doesn't really matter what they're taking the bisphosphonate for. If they've had it in the past, they're high risk. If they're taking it for any malignant condition like bone cancer, Paget's disease, osteogenesis imperfecta, they're high risk. If, for example, they're taking steroids, systemic corticosteroids at the same time, high risk. If they're on a coagulo, chemo, or radiotherapy at the same time, they're high risk. Now, in high-risk patients, what we do is we're first going to consult the OMFS, see what they say. If they say we can continue the treatment in primary care, we continue. Of course, keep reviewing them, making sure that the bone's healing fine. Otherwise, if they think that the patient shouldn't be treated in primary care, then we refer the patient to OMFS for all treatment, and we just keep reviewing the patient. Now, the risk of actually developing bisphosphonate-related osteonecrosis of the jaw is actually very small. It's 1 in 10,000 to 1 in 100,000 patients who are on bisphosphonates a year. Now, since this is such a small number, this is why that's why we try to avoid procedures that can be traumatic for the bone. However, it's not something that we, have to, under all circumstances, not carry out for the patient. For example, in OSCE, there's an OSCE in which a patient has irreversible pulpitis, and the patient, we basically have to give the patient the option of root canal treatment or extraction, and of course we have to tell the patient that it's preferred that they go for the root canal treatment as opposed to the extraction because of the risk. It's a low risk, but there is a risk. We have to advise the patient not to stop taking the bisphosphonates. Why? Because this is the kind of medication that stays in the body for years. Even if the patient were to stop taking the medication, we were doing the treatment next month, the medication would still stay in their body. Even if the patient does stop taking the medication for whatever reason, we're going to classify them in the same group, that is low risk or high risk, depending on what their risk category was previously. Now, lastly, the names of some of the famous bisphosphonates are, the way you can recognize is dronate. So if it's ending in dronate, then it's most likely a bisphosphonate. And there's an alendronate, which is Fosamax, then residronate and pamidronate. So that's all about bisphosphonates. If you have any questions, just comment below. Thank you.